Morning friends, I am Arun Kakar. I was a professor of surgery in Malanzad Medical College. I retired in 2012 and has been fortunate enough to be with you guys who are doing DNB in general surgery and at times some of the CMEs who interacting with you young folks who would be doing post-graduation in surgery. It's sad that some of you are jumping straight into super specialties like neurosurgery, cardiac surgery, or urology without doing general surgery. It's my personal opinion, I may be wrong, that to be a complete surgeon, irrespective of which part of the body you are specializing in, you have to have a broad outlook about all the system, and that can be covered only if you do a general surgery. I think the good old tradition that you do general surgery, you do a senior residency for a year or two and then go into super specialty had a merit, and I still think it has a merit, rather than do your MBBS, do internship and then get into a 5 years of super specialty, whichever you want to. Because there are few things which are not dealt in that super specialty. That's my experience. Of course, I may be wrong. But I know in the hearts of hearts, many of you who have not done a general surgery would realize that it does make a difference. For example, you're doing a urology. You get a case of urological problem and the person has an associated peripheral vascular disease. How many of you would be able to clinically evaluate that patient? You would straight away request your colleagues in general surgery or in vascular surgery. In a way, you may be right, but don't you think it is necessary that we should know how to evaluate the peripheral pulsations, how to record a history? A person who's come to you with a kidney problem doesn't mean that he can't have associated gastrointestinal or a vascular or a pulmonary problem. We have divided the body into various segments, and similarly, unfortunately, we, including so-called faculty, had divided our brains into various segments. That my brain will only be handling urology. B person's brain would be only handling neurosurgery. That doesn't work out. I'm afraid that's not true. It's not rare that sometimes the general surgeon is called to put a insert a Foley's catheter in a 55-year or 60-year-old man who has undergone a craniotomy. Why? Because the neurosurgeon doesn't have enough experience. Taking that as a background, I think it's important to know how to evaluate a person who comes to you with a peripheral vascular disease. And the common peripheral vascular diseases that you come across are thromboid angiitis obliterans in the lower limbs, atherosclerosis, and in the upper limb is vasospastic disorders like, obviously, there is a chronic arterial insufficiency. That's about the examination of pulsations in the lower limb. As we said, maybe 1 in 10 with Burgess disease have a pathology in the or involves the vessels of the upper limb also. And when it is atherosclerotic, it may actually be starting somewhere in the abdomen and manifesting in the form of chronic ischemia of the lower limb. So, it is important to examine the pulsations of aorta, the common iliac and external iliac artery. Now that the patient is supine, at the same time, in the same position, one can palpate for pulsations of aorta. We all know abdominal aorta is slightly to the left of the midline. And somewhere at the level of L4 or so, about a centimeter or two below and to the left of umbilicus, it divides into common iliac. And if you join this point with the mid-inguinal point, the proximal 1/3 represents the common iliac pulsations. So, for palpating the aorta, you palpate at the level of umbilicus a little to the left side against the body of L4. Common iliac a little down on the left side and similarly on the right side against L5. Internal iliac artery pulsations cannot be felt because it immediately turns inside and starts dividing, and it's not possible to palpate the pulsations of internal iliac artery. External iliac, well, if you palpated a common femoral artery, that's good enough. It's a rare occasion unless an ambulus which is stuck. Most of the ambuli get lodged at the bifurcation or at the origin of major branches. So, this is not the site where ambulus gets stuck, but you can palpate the external iliac artery just above the inguinal ligament. Below the inguinal ligament, you palpate the femoral artery. Having done the examination of pulsations in the upper limb, the next thing is how to examine the pulsations of the upper limb. The best way is make the person sit up, and like in the lower limb, we look for any evidence of chronic ischemia in the form of tapering of fingers, in the form of loss of hair or scanty hair, in the form of atrophy of skin, form of atrophy of the muscle compared to the opposite side, any temperature changes. When you come to palpation of the vessels, you start from distal to proximal. And we all are familiar with palpation of radial artery. I may say, why are we discussing about it? It is so easily palpable. What's the big problem? Against which bone are you palpating the radial artery? And obviously radius. But which part of radius? Is it the styloid process? If you remember, the lower part of the shaft of radius is quadrangular.